Hello everyone, it's Max again. I'm back for the final iPad lecture. Today we're going to talk about rate, rhythm, and axis, but first let's talk about the components of the cardiac cycle. As you can see, I'm labeling the EKG with a P wave, a QRS complex, and the T wave. Each of these waveforms signifies an important part of the myocardial contraction and relaxation. The P wave stands for atrial depolarization. The QRS complex demonstrates ventricular depolarization as well as atrial repolarization, and the T wave is where the ventricles repolarize. The specifics of depolarization and repolarization could be a lecture in itself. The EKG is a display of time on the x-axis, usually set at a standard speed of 25 millimeters per second. The other important parts of the EKG are the intervals. There is a PR interval, a QRS complex duration, and a QT interval. The PR interval is measured from the beginning of the P wave to the Q wave. Unfortunately, it's not the R wave. The QRS complex represents how quickly the ventricles depolarize, and the QT interval displays how effectively the ventricles can repolarize or relax. Now, the normal PR interval is between 0.12 to 0.2 seconds, or 120 milliseconds to 200 milliseconds. And the QRS complex should be less than 0.12 seconds, or less than 120 milliseconds. The purpose of the PR interval is to allow the ventricles to fill with blood adequately. Now let's take a look at some of the boxes that are displayed on an EKG. In its simplest form, the EKG is made up of little boxes and big boxes. One little box is 0.04 seconds, or 4 milliseconds, and one large box is equal to 0.2 seconds, or 200 milliseconds. So another way of describing our PR interval is that it should be between 3 little boxes and 5 little boxes, or between 3 little boxes and 1 big box. The QRS complex should also be less than 3 little boxes. As you will see in the next lecture, a quick way to see if the PR interval is the right size is to quickly look at 1 big box. At this rate, we'll probably be some star employees at FedEx. Another important numeric on the EKG is on the y-axis. Each little box is equal to 1 millimeter. And this is important in evaluating the size of ST elevation or depression or determining if there is hypertrophy in the myocardium. The next topic we are going to discuss is the conduction system. So, what is making the P, QRS, and T wave? The heart is capable of using its pacemaker cells to create its own action potentials outside of extrinsic impulses. This all starts up in the atrium with the sinoatrial node, or the SA node. The next tissue is the AV node, or the atrioventricular node. We then move downward into the interventricular bundle, or the bundle of His as it used to be called. This bundle splits into a left and right bundle branch, and further into small Purkinje fibers. The way I like to think about this conduction system is using highways, main roads, and back roads. When you're using the conduction system appropriately through the SA node, to the AV node, through the bundle, down the Purkinjes, and then to each cardiomyocyte, you are effectively using the highway system. The highway works appropriately when there is no backup or traffic that can cause delays. Keep this idea of the back roads and the highways in mind as we move forward to look at each rhythm. With that being said, the basis of all cardiac rhythms can be split into 3 sections of the heart, which I will label number 1, 2, and 3, starting at the SA node, then at the AV node, and down to the back roads of the cardiomyocytes. The first area is dominated by the presence of a P wave. This P wave is upright, round, and before every QRS complex. This is the way it is because the impulse originates at the SA node. This node has an intrinsic rate of firing or depolarization of about 60 to 100 beats per minute. This is termed a sinus rhythm. For there to be a sinus rhythm, there needs to be, again, an upright P wave that is round with a normal PR interval that precedes every QRS complex. The next area, which originates around the AV node and in the interventricular bundle, is denoted by the lack of a P wave, but still having a narrow QRS complex. This is because, as we remember, time is on the x-axis. We are still utilizing the highways, but traffic has slowed us down to a rate of about 40 to 60 beats per minute in this termed junctional rhythm. The final area is in the backroads of the conduction system. We no longer are utilizing our highway system and we have to drive from cardiomyocyte to cardiomyocyte. This has severely slowed us down, and we notice this by a wide QRS complex and a rate of about 20 to 40 beats per minute. Just like in a junctional rhythm, we do not have a P wave for every QRS because the SA node is not facilitating this conduction. However, the QRS is now wide and slower. This rhythm is termed a ventricular rhythm. Understanding these three areas of the heart are very important for applying them to the different arrhythmias we will see in the next lecture, and this will help you understand why certain arrhythmias behave the way they do. Next, I'm going to talk about the cardiac axis. So first I'm going to start by drawing a heart with a central point. As we know, lead 1 goes straight across the chest. I'm going to add that in at 0 degrees. Then I'm going to add in lead 2 in the direction of the major vector at 60 degrees. As well as lead 3 at positive 120 degrees. Now, just so you guys don't think I'm making this stuff up, I'm going to duplicate these arrows and I'm going to arrange them into, I don't know, let's say a triangle that we've seen before. As you can see, the cardiac axis system is just a continuation of Einthoven's triangle into a coordinate system. So let's continue adding vectors to our diagram. We're going to start by drawing AVL, AVR, and AVF, which are 90 degrees to Einthoven's leads 1, 2, and 3. And now I'm going to add in the final 2 points at negative 90 degrees and 180 degrees. The cardiac axis is typically a result of other pathology, i.e. if there is too little muscle or too much muscle. If there is too little muscle, like from a myocardial infarction, then the axis will shift away from it. If there is too much muscle, the axis will shift towards it. So let's remind ourselves what the normal conduction system is. We start at the SA node in the atrium, then move to the AV node, down the interventricular bundle and to the Purkinje fibers. So because this major vector is going towards lead 2, and in this area between 0 and positive 90 degrees, we can say this is a normal axis, highlighted in pink. The area between 0 and negative 30 degrees that I highlight second can sometimes be called a physiologic left axis deviation, or just be included in the normal axis. Now let's say we have too much left ventricular tissue. This can shift the axis upwards towards negative 30 to negative 90. This area I will highlight in green, and it is a left axis deviation. Now if the opposite occurs, where there is less left ventricular tissue, this pushes us towards a right axis deviation. So I hope I haven't lost anyone in the minutiae of the cardiac axis. I'm going to teach you a quick way to calculate this, using your thumbs. Your left hand will be lead 1, your right hand is AVF. If both of your thumbs are pointing upwards, you have a normal axis. Let's say lead 1 becomes negative. Now your fingers are touching each other, they're right for each other. Let's do the opposite. If AVF goes negative, your fingers have left each other. You have a left axis deviation. And if they're both down, that's an extreme axis deviation. Now that we covered this, in the next lecture I'm going to talk about arrhythmias. Thank you so much for listening.